in the whole planet. I think a lot of reason why we as EM practitioners want to learn point-of-care ultrasound in the first place is for this very reason. Now, Arun just did a fantastic job of showing you how to get some views, including echo and lung. So a lot of this is going to be a review, and we're going to go through some cases. But these are a couple images you haven't seen before. Anyone want to hazard a guess as to, oh, sorry, as to what, oh, this one might be showing you? So this is a 19-year-old who syncopized when he was playing hockey. And he comes to you hypotensive, but all he wants is a clearance to go back to playing hockey. You're going to give it to him?
Okay.
What do you want to do? Yeah, so this is hokum, and I love showing these ones. So this actually was taken by one of my second-year medical students. And I love it because it shows them the actual physiology of why hokum is devastating and why this needs to be picked up pretty easily. But that scares me because now do I have to screen every 90-year-old who faints and who comes to the ED? I don't know.
Just me.
How about this one? So peristome lung view. And I'm going to start a hashtag that's called the dot right movement. So that supports our right-sided screen dot. Okay. This is endocarditis. These are vegetations on the valve. And now TTE isn't the most sensitive or specific for this, but if you see it on TTE, your specificity just went way up. So that's what that happens to look like on the mitral valve. Okay. So the reason I hate the way we learned about shock in med school is because we learned it like this. And I don't know anyone who remembers it like this. If I see this chart, here's my shocky face if I were a white, redheaded girl. But that makes me do this. And so when someone comes to you as a patient, you're also not approaching them like, let me go through my 4 stages here, right? We just don't clinically practice like that. And so the beauty of ultrasound is that we can cut all this out. And essentially what we're trying to do is we're trying to look at parameters of these guys. But I don't think about patients in mathematical formulas. The other thing I don't like about kind of the way we approach shock is that it seems like there's separate distinctions, when in reality, our shock patients can't talk to us sometimes. We can get no information, or we get too much information. And really, by the time they get to us, we're in a shock combination. So we're not dealing with one kind of shock. How long does it take for you guys to get the lactate back? Do you guys have point-of-care lactate?
Yes.
Oh, okay. We didn't have point-of-care lactate for a long time. Even that one takes probably 10 minutes if it hasn't been screwed up. So our lactates used to take us 2 hours to get back. And we don't have. How long does it take for you guys to get a CAT scan?
2 hours.
2 hours. Dudes, you are beating us here. Sometimes it can take me 5 hours to get a CAT scan. 7 hours by the time it's read by the radiologist. Depending on how busy it is. What about formal ultrasound? How long does it take for you guys to get back?
2 days.
Okay. See, that's more my style, right? Okay. Right, and so, I'm not preaching to the choir here, more the reason why we should be doing this. So we'll start with the case, and we're going to have a 60-year-old who is essentially found on the floor by her family. She is responding to her name only, so won't answer questions, and she's not moving the whole left side of her body. She does have some droop, and she's complaining of left back pain. She's quite hypotensive, and the rest of her vitals are there, and so she comes to us as a stroke code. So, the stroke algorithm gets activated, so CT, angios, and all this kind of stuff. And we're waiting for all that stuff to happen, but her blood pressure drops precipitously. So this is what happens to me when I pretend to know what I'm doing. That's my outside face. This is probably my inside face. And I want you guys to remember this case because we're going to come back to it at the end. All right? But, someone comes to you as a stroke, And what other differentials might be there? Dissection. She fell on the floor, so maybe trauma in there somewhere. And we're left with, even though it sounds like a kind of clear pathway, we're still left with several different pathways. If you read the literature, there probably are like 15 to 20 different kinds of shock algorithms, all of which have their own 4-letter acronyms. So there's fields, there's falls, there's cause, there's clue, there's I don't know. This one happens to be my favorite. And it stands for Rapid Ultrasound and Shock, so RUSH. If anyone here follows Scott Weingarth, he has his own version where it's RUSH High Map, and High Map stands for Heart, IVC, Aorta, Morrison's pouch for your fast exam, and pneumothorax. So there's different versions of this. But the reason why I like this one is A, it breaks up the body into IKEA, and I like going to IKEA. And I also like not getting lost in IKEA. So it provides a nice roadmap there. And it also tells you when to do it, because you should rush to do it. So now if we get hypotension alerts or code activations from the field, our techs actually know to put the ultrasound in the room already, so I don't have to go hunting for it. First, we're going to start with the pump, and that's pretty self-explanatory. The pump is the heart. Is it working or is it not working? Arun just gave you a really nice recap of the views. So once we have those views, he talked about ejection. We teach something called the 5 E's because it's a kind of nice algorithm for people to understand what pathology to look for. So 5 E's. First E, do we have a pericardial effusion or tamponade or not? 2, what is the squeeze of the heart like? What's the ejection fraction like? 3, is my RV enlarged? Equality. Do I need to worry about a PE? 4, what is the diameter of my thoracic aorta, and should I be worried about thoracic aneurysm or dissection? And 5, I include IVC always with my echoes. What is my preload? What is my entrance going into the heart? The heart probably will give you 90% of your answer in shock cases. And, you know, I'll go through it at the end, but we rarely go through the whole RUSH algorithm. We mainly stick with the pump and then the tank. So we got a youngish guy. He's feeling pretty well. He does have a cardiac history, diabetes. He's got risk factors. He's been a smoker for 20 years, and he suddenly clutches his chest and becomes diaphoretic. EMS find him in asystole. So they have ACLS ongoing. When they had a rhythm strip, they were able to get this. Should they do a field cath lab activation? Do you guys have that here? Can EMS activate the cath lab? Yeah. So they activate the cath lab, but then they make a pit stop with us because he becomes asystolic. What's going on? How's the squeeze of the heart? Do I have an effusion? Does this look really weird to you?
Yeah.
Is it a mechanical advisor?
So this one, it was mechanical action. This is what happens when you're looking at compressions under CPR using TTE. This is a subxiphoid view, or subcostal view. This is my liver, and here's my heart. So this is what happens. So the machine, the Luke is on, and your liver is going underneath it in a subcostal view to get this. First pulse check. 5 E's. Do I have an effusion?
Yes.
Majority say yes. Is it small or big? Big. Okay. And what other properties does it have? Is it fresh or? So it's clotted. Okay. So now we have dry blood in here. That's not good. Ejection? Okay. That's a gimme. Equality? Fine. Okay. Exit we can't tell, and entrance we can't tell because this isn't the right view. What do you think we're going to do from here? Should we call it, or should we continue? What else do we have besides those 5 E's that we mentioned? Yeah. So this would be FIB, this is shock, right? So I vote for continuing ACLS. They actually did a pericardiocentesis before shocking. And even though it was clotted blood, I don't know how they did it, somehow they managed to suck up some of the blood, shock it, and they got ROSC. Does anyone here see a reason why this happened in the first place? So we haven't quite, we talked about this yet. So I know this is my dot right view, but here's the thoracic aorta. Let's see. So we measure from the outside wall of one part of the wall to the inside. That's by convention how you measure a thoracic aorta. So I'm going to 1, 2, 3, 4, just about 5. Normal is 4 centimeters. Completely abnormal is over 4.5 centimeters. So what probably happened was you have a thoracic aneurysm or thoracic dissection that has ruptured near the root, causing the pericardial effusion that was tamponade. Had that person gone to cath lab, how do you think this would have ended up? Not great. And as Arun just mentioned, tamponade causes obstructive shock. Your IVC is going to be completely blocked, and so much so that we see this low flow state that we call smoke, where the sound wave is literally pinging off each individual RVC because the blood is going so slowly. And this is called smoke. What are the features of tamponade again? What are you mainly looking for? Okay, so RV, diastolic collapse, is one of the first signs. Second sign becomes RA systolic and RV systolic and diastolic collapse. So really, we're looking for the RV free wall here to collapse during diastole. This can be hard to tell. We can show you how MO can help you. But just a reminder that for tamponade and pericardial effusions, it can actually happen with very little fluid. So just because this doesn't look like that much fluid doesn't mean that there's not tamponade. Anyone understand all my double negatives there? How about this one? This is a peristernal short view where, again, we see this clotted blood, and it literally means that the RV cannot fill anywhere. Chris had the John Travolta sign. Some people also think that the tamponade looks like a T-Rex. So T-Rex sign also can be, indication of a tamponade. All right. I can't quite see it, but you know. And I got to tell you about one of my favorite cases from last year. A 50-year-old was driving from Boston to New York. So if you know anything, anyone here know where New Haven is? Chris, you don't count. So New Haven, where Yale is tiny. It's this small city that's right in between Boston and New York. So we get a lot of traffic going from Boston to New York or Washington, D.C. And this guy was driving from Boston to New York, was listening to NPR, our National Public Radio Service, right around election time, and was getting madder and madder and madder until he went, ow, and didn't feel so good, so he decided to pit stop into our ED. So it was one of those days where you're running around the resuscitation bay trying to put out fires, and so my resident comes and says, Rachel, we have a problem. I'm like, why? EKG doesn't look that bad, right? But then she said, well, okay, subxiphoid view, right? Does this worry you? Yeah. So we have an effusion. Is it tamponade? Anyone? So we're looking for an effusion that goes all the way around, which it does. Do I see any collapsing of the RV free wall? at the apex, okay. I'm specifically looking in diastole though. So diastole is when the valves open. So I'm going to remove this because it's distracting. When the valves are open, is the RV dilating all the way? I don't think this is tamponade. Do you guys agree? Okay, so I said, why are you getting so excited? Because I still don't have tamponade. This person isn't in distress because of tamponade. Why are you so worried? Then she was like, Rachel, dilated thoracic aneurysm with an effusion is always going to trigger the crap, something is dissecting and rupturing. Right? So this guy goes to the OR within 2 hours and is saved after having 50 units of blood, and is quite delighted with his diagnosis because now he thinks he's got a reason to sue the government, which I would have supported him with. We don't do these very often anymore. How's the squeeze? Non-existent, right? And when you have a heart that's not beating, it can actually be really hard to tell what your echo is. So we're actually in a peristernal long view here, and here's my myocardium, but then all this fresh, like black stuff is fluid, and if you look really closely, there is a needle. So they tried to do an ultrasound guided paracardiogenic. When you do this, the fluid actually makes it nicely easy for you. You go where there's the most fluid. If this part was beating, I probably would not have chosen this area to go to. I would have chosen to go out more apically. But you know, people worry about pneumothoraces and things like that. When you have fluid, it pushes your lung out of the way. So if you went by your apex and stabbed at your apex, you probably won't have any lung injury. So with ultrasound, guiding your pericardiocentesis becomes quite easy. You can forget the textbook and go where you see the most fluid, whether that be subcostal, apical, or peristernal. Okay, you guys know what's coming, right? A 62-year-old female, she starts feeling poorly at church. She also has cardiac risk factors. She faints and she is found pulseless. A subcostal view again. What's going on? CPR, okay. First pulse check. Do we have an effusion? No? Okay. We know ejection sucks. Equality. So this is the right side of the heart, this is the left, and I have this pretty globular RV. And not only that, I have schmutz in there. And then we got to be careful with this because there's now newer literature saying that for some reason the RV will dilate during CPR and during the coding process. But this lady hasn't been coded very, very long, probably about 10 minutes. And so I'm thinking that stuff in there is not like old, decaying blood. So what do we do? Continue ACLS, this is our continued monitoring. Three boluses of TPA is what we did, because why not? I know that's not an FDA-approved use of TPA, but you know, this person's dead afterwards. So this is what happens after TPA and support, and we get ROS. So all this is being done real time. The question is, that we'll come up to in a second, is, oh, here, before that. This is on a tablet machine. This is what happens when your whole IVC is clotted. You can't discern it, and you can actually see there's a little bit that's coming into your RA here. If that breaks off, now you have a clot in transit. All right, so I just wanted to show you what it can look like with these newer tablet machines, because the image quality for these is actually getting quite good. Ejection. this is, so, this one here. So this is a peristernal long view. These are the same patient. What do we think happened between these two patients? I mean, sorry, between these two images. This is the same patient. So I have a crappy squeeze, in which case I want to give maybe some sort of pressor. That might be an inotrope. So we gave dopamine. Some cardiologists prefer dopamine. Does anyone here have a dopamine shortage, by the way? No? Is that only happening in the United States?
Sure.
I don't think anyone uses it.
Because we have
Yeah.
music and
What do you guys use?
It's probably a sad
Okay. So that's actually pretty interesting. I don't know if you guys are having the same problem. We're having a lot of shortages of very regular medications because of our pharmaceutical industry, which will lead me into another rant. But anyway, we have problems getting pressor sometimes. So what we did was we started with inotrope and transcutaneous pacing. So between here, this rather symptomatic bradycardia here, we transcutaneously paced as well as gave an inotrope, and now I get a peristernal short that seems to be moving a little bit better than this one. Is it moving better in a symmetrical fashion? So this is what we call, the focal wall motion abnormalities, and indicates my cardiogenic shock. So cardiogenic shock, I can activate the cath lab because my whole lateral posterior inferior wall is taken out, and I can presume that this is because of an MI. These can happen before you get EKG changes, and can happen before your troponin comes back. And so what we've done in our system is if we see focal wall motion abnormalities, we activate the cath lab, they will prioritize that person. They will trust what we say, prioritize that person in case we get multiple STEMIs at once, they will take that person first. Any questions so far? Okay, so this is the really cool stuff. Right? What do you think about the CPR? We do not teach this routinely in our echo courses, and I think we should start. Good, bad? You only have a 50-50 shot here.
The ventricle doesn't squeeze.
How would you tell this person to improve?
Sorry, what's the question?
How would you tell whoever's administering CPR to improve? Too fast, good. So it's too fast, and you're right. Here is the LV, here's the RV. There's no compression of either chamber. That means these compressions are way too shallow. Is this easy to do? It's not really. This is the whole reason why Lindsay had this whole TOE talk, because this you can't really do in everyone. But I'm advocating for it more and more because we're not improving our ROSC outcomes, especially for out-of-hospital cardiac arrest. There's something that needs to change with the mechanisms that we currently have, and most of us don't have TOE at the moment. And establishing a TOE program probably will cost about $200,000 for me to do. So if I can do what we're trying to do with TOE with transthoracic echo, why not? You're not going to get pristine views. This is not a normal peristernal long view that you're used to seeing. But I have a feeling that as POCUS providers, we actually get really good at determining pathology off shitty images, right?
Yeah.
We get really good at that, and this is, you just get it however you need to get it. How about this one? This is a peristernal short view now. Feedback? Adequate? No. What would your feedback be?
Slow down.
Slow down. So this is actually happening with the paramedics who are on scene with you when they're dropping off the patient. Before they even take their hands off, I'm doing this so that we can try to provide continuous monitoring of their CPR. Not the easiest thing to do, but there's 2 papers that just came out in this year alone that said trying to do monitoring during pulse checks is delaying our compressions. Actually, Arun, a senior author, on one of those. So, if we're having so much problem during our pulse checks, why not do it beforehand? Why not do it as soon as you can? Right? This is with the Lucas. What do you think? This is very interesting in the pre-hospital world because the Lucas was supposed to give us a lot better outcomes, which hasn't borne out. Do you think that the Lucas is delivering effective compressions? Here's a peristernal long view, and my LV isn't getting compressed at all. What do I need to do? We took off the Lucas, and the problem with that previous one was the LV wasn't getting compressed at all, even though the Lucas is on anatomically correctly, which means my heart is more left-sided than we predicted. So this ACLS one-size-fits-all approach to delivering CPR is not effective. And maybe we need to use ultrasound to look at where people's individual hearts are in order to deliver effective compressions. What about defibrillation decisions? So there's a pile of literature that says if you have, cardiac standstill, your CPR and the futility is going to increase if you see cardiac standstill. So maybe you should just give up CPR and give up ACLS. But if you look at those papers, a very small percentage of them survive to hospital discharge. Why is that happening? How can 1.6% of the population, the study population, be surviving to hospital discharge if they were dead? And we think this is the reason. What are you seeing here? This won't pick up necessarily on your monitors. And I think this is because, for some reason, the way the electrodes are built, they're not sensitive enough to pick this up, particularly in larger, obese-er people. Is obese-er a word? Okay. And then this is a series of ROSC after this person got shocked. This is final ROSC after 15 minutes of this arrest period. These are a couple more examples of what fine VFib looks like. This one's hard to tell. The images are grainy. Again, we're using data off shitty images, which is perfectly fine for me, as long as I can tell what I need to tell. So I'm looking at the valves here, and they're doing this flickering thing. This one is a better image because both the muscle here and the valves are doing this fibbing thing. You guys like these memes? Don't shock asystole. Okay, so I'm not saying to shock asystole, but I'm saying if you see asystole or PEA, we should be taking a look with ultrasound to make sure this isn't happening. Okay, one last case of this because this is very, very recent. 40-year-old guy was told by his mother to come down for dinner. He says, okay, and then she hears a thud. She goes up, finds him face down on the floor, and has no bystander CPR for 10 minutes. Nothing. A BLS unit, so basic life support, not even advanced life support, was called because it was called as a fall. So there was no advanced life support. So they start CPR just with their basic things, no intubation, just a king airway, and no other kind of parameters that we usually use for raw success. So they do nothing. It's been 40 minutes by the time they get to me. This is what their thumper was doing. This is Lucas. And again, these are not the greatest pictures, but how do you think compressions are going here? Not. Here's my LV. There's no LV compression at all. And the other clue that it's not being delivered in the right place is the heart is rocking diagonally like this, right? It's not being squashed up and down. It's going like this because the thumper is literally pushing it in and out of place. So we take the thumper off. diagonal thing, at least now I'm getting some recoil and collapse of the LV. Can you guys see that, or is it really obscure? It does take some practice to kind of like look at these for a while. Okay, so we continue at ACLS, and after 3 pulse checks, we get this in the pulse check. Oh, sorry. Go away. Okay. What do you think? Twitching? Yeah, it's, so I'm calling this as fine defib. We shock once, doesn't work, nothing happens. The next time we do a pulse check, we still see this. So now we're in refractory defib. So we do double sequential shock. And that works. Here's Rob's. Now the problem with this is, that's great, I just did it in my ED setting. We now have a downtime of 60 minutes because he essentially had 40 minutes of ineffective CPR. So what did I do? I made this person survive for organ donation, essentially. He's pretty good. So what if in the pre-hospital literature and pre-hospital studies, even though we have a lot of problems with pre-hospital studies right now, what if this can be looked at more? What if that person, that 40-year-old, had gotten effective CPR? I think the outcome probably would have changed. These things are being written up as a case series that I'm going to contribute to, yet another case series that Lindsay can point to later. But, you know, this is, if you look at those images, it's spanning from 2012 to now. These are a series of cases that we've collected just based on anecdotal evidence. This is really hard to do prospective studies on. So that's going to give me a blocked IVC. This is what happens when your heart has no volume. This is a dialysis patient who probably got too much dialysis. And up here, coded, there is no volume in my RV. I can't see my LV very well, but there's not very much volume in here. And so they spent about 15 minutes flooding him with fluids, and now we have a little bit of stuff. This I don't think is going to generate a life save, but just in case you're interested, that's what happens when your whole heart is depleted of volume. And I gotta say, when you're really, really dehydrated, it's really hard to see your IVC sometimes. So here's a very thin strip of fluid here that indicates your IVC. Hard to tell. That's a summary of the pump. And I hope with those series of cases, you can start seeing how we do resuscitation and shock assessment at the same time. So I spent the most time on the heart. We're just going to quickly run through the rest of them. We're going to move to the tank. And the tank is any reservoir that can carry fluid. Essentially, your EFAS exam. Okay. You guys all comfortable with the EFAS exam? 9-year-old female with both CHF and COPD. I don't know how uncommon that is. That's like an everyday occurrence, where she's coming with shortness of breath, and she has both a wheeze and rails that EMS heard. And so they decided to give some Duanebs, as well as Lasix. I don't know if they can do that here, can they? So they give both treatments, and she comes in hypotensive and hypoxic. As Arun said, I rarely do isolated lung exams. We do something called the focused chest exam, where we start with the pump first. If I don't have a great answer, then I'll move on to the tank. So, not bad for 90 years old, I gotta say. Effusion? No. Ejection? Good, right? Equality? You know, not bad. Exit is, you know, pretty normal, I think. And what about entrance? Is the IVs dilated or flat or neither? So what pathologies can we rule out automatically? So it's unlikely to be decompensated systolic heart failure, but they have given Lasix, so that's not going to help our cause here. And it goes so far, we can't figure that echo looked pretty normal, so then we even did a diastolic assessment to see if she had diastolic heart failure, which I will just say these are normal. Yeah, I can show you in the hands-on stuff, but this is normal. So now we move on to the tank, so I'm going to add in my lungs, and what do I see? B-lines, okay. Bilateral, unilateral. This is right and this is left. Unilateral B-lines, and so what condition also don't I have? I don't have, that supports that I don't have CHF. When you see B-lines and when you see lung sliding, it also supports that you don't have a pneumothorax. So great, now I isolated two life-threatening, problems. We didn't go through this yet. So this is the kind of high, fast, coronal view where we're looking for pleural effusion. This versus this.
Consolidation.
Yeah, so this is normal. Here is the right side, and I've got spine sign. This is my spine sign. When you see the spine sign, it means something is abnormal. I can explain that a little bit more. It means that I can't see my thoracic spine if I have normal lung tissue, because my normal lung tissue is full of air and will scatter sound waves, so my sound waves can't even reach my thoracic spine. If I see my thoracic spine, that means there's something in there that can transmit sound waves, either pleural effusion or this is a consolidation, this is pneumonia. That's what pneumonia looks like. We've got the air bronchograms in here and this tissue that looks like liver tissue. So, doing a combined heart and lung exam, we were able to exclude CHF, no B lines, exclude CHF or ARDS or anything like that. We have unilateral B lines, which supports a more focal process, and then we isolated the focal process that's a consolidation and pneumonia that's causing her sepsis. I'm not going to go into the abdominal part of the tank because I think you are pretty comfortable with the fast exam and know what free fluid in the abdomen looks like. I will have to say, for the abdomen part, if I don't find an answer in the thorax, I will automatically look at kidneys and the gallbladder, because cholecystitis hides in old people. Right? So I'll always look at the gallbladder if I have no answers up until this point. This is what cholecystitis looks like. I'm looking for this angry gallbladder wall, and we just had this talk earlier today about whether we look at CVD or not, and that's still debatable, but I'm mainly looking for this angry gallbladder wall with a stone that's hiding right in the neck there. This is what pylo looks like. So I have my kidney, and this whole collecting system, there's a little dilation, but there's a lot of echogenicity in this middle area, and that's like pus and debris that's collected there, so it's more echogenic than you would expect. That's what pylo looks like. Okay, so lastly, we come to our pipes. This is literally the last thing, last-ditch thing. We don't normally get to this point, but if we haven't found an answer, then I might consider going here. Remember that first case? The little lady, well, she wasn't that old, she was 60 years old, who was found on the floor with left-sided back pain and not moving her left side. So as she is being wheeled to CT, she keeps saying, "Oh my back, oh my back." So we start doing a trauma eval, or the resident does. This is a right upper quadrant view coronal that we start our fast with. Free fluid or no free fluid? Who says yes? Okay. Who says no? And who says, "I really don't know, help me out"? So, in this Morrison's pouch area, I have a very small sliver of fluid here that is irregular. Free fluid takes the shape of irregular containers, so it's kind of looking weird there. I just wanted to point this out because when people teach the FAST exam, they show flagrant examples of positive free fluid. The FAST exam is not as easy as you might think. So this is an example of positive free fluid from that. What are we seeing here? So here's my spine, here's my huge aorta. This aorta has rupture, When I have an aorta rupture, should I get a positive FAST exam? How come? So the aorta is retroperitoneal. However, if you lose enough blood, it can spill over into the intraperitoneum. That is a bad sign, and that is a harbinger of death here. She's already hypotensive. And so the discussion was had with that family whether they wanted to try to do rescue surgery, of which she probably had a very poor prognosis, or make her confirmation only, and they chose confirmation only. So this was the ticking time bomb that probably progressed over 3 hours. These are a couple more flagrant examples of dissections, and this is literally one of my favorite pictures ever, because you can see the aortic dissection through a pleural effusion. And the providers didn't realize they were picking up the aortic dissection because they thought that was the heart, and forgot that the heart does not directly overlap the spine. Yes, so fortunately they got a CT and didn't miss that. But here is your dissection flap right there, and dissection flap with a tether ball in it right there. And we can't mention the pipes without mentioning DVT. I don't focus on this so much because DVT is not acutely life-threatening. However, if I really suspect it, I might go here first, because the nurses and whoever are doing all of this roll pads and whatever up here, so I might choose to go look at DVT first. So there we have it, a summary, case-based, of your pump, tank, and pipes evaluation of the rush exam. And all you have to do is echo, EFAST, and aorta and DVT if you need to. And this helps us break down the way we learned in med school to get what we need to.